So welcome to the fully guided full arch immediate implant reconstruction webinar being presented by the world-renowned Dr. Michael Picos, and we will begin the webinar shortly. And now I get to turn the reins over to our very own Terry Capriolo, General Manager, Implant Solutions and Guided Surgery, as she will be introducing tonight's guest lecturer.
Thank you, Jessica. Good evening, everyone, and thank you for joining us. As mentioned, my name is Terry Capriolo. I am the GM of Implant Solutions and Guided Surgery for National Dentex, and it is absolutely my pleasure and honor to introduce our speaker tonight, Dr. Michael Picos. Dr. Picos is an oral and maxillofacial surgeon and the founder of the Picos Institute, where he has been teaching a continuum of bone and soft tissue grafting along with CT technology since 1991. A graduate of the Ohio State University and College of Dentistry, he is a well-published author who has lectured extensively on implant surgical reconstruction around the world. In addition to his numerous professional organization memberships and university faculty appointments, Dr. Picos maintains a private practice in Palm Harbor, Florida, that is limited exclusively to implant surgical reconstruction. I have personally known Dr. Picos for quite a long time now, and he has been at the epicenter of the build-out and continued growth of InSequence. He is a world-renowned key opinion leader and influencer and is beyond committed to education. He is not only an outstanding clinician and key educator, but is a good friend. NDX InSequence is so thankful to Dr. Picos for all of the extraordinary partnership and support over the years. Thank you so much, Dr. Picos, and I will turn it over to you.
Well, thank you, Terry. And indeed, it's a pleasure and an honor to have this webinar this evening. Lots of material to cover, and I do want to get things started here for sure, but I want to give thanks to you, Terry, and your entire team for really doing such an amazing job with this technology and bringing things to where they are at right now. Certainly, it's been an evolution over time. I've been involved now since, goodness, 2009, I believe. It's just amazing how fast time does go by. But at any rate, my pleasure to be involved now with this webinar, fully guided full arch immediate implant reconstruction. Just a disclosure right up front to be just on very transparent with everybody. I am a consultant with the InSequence folks. However, those of you that know me well enough know that I tell like it is. I don't sugarcoat anything. And with that said, my presentation will be based on material that is of my own only. And I'll talk more on that here in just a bit. Just a little bit of background on me. I'm approaching my actually 39th year of completion of private practice. Hard to believe the time goes by so fast. But it's been quite an enjoyable journey, to say the least. I'm fortunate with our coastal jaw surgery team to have some amazing people with me, some really superstars that are just so energetic and make things happen for us. There are four of us are surgeons. Besides myself, we've got Kenny Anderson, who hails from Minnesota. We also have Nicole Hernandez from Tampa, recently joined us almost 2 years now, actually, from trained actually in San Antonio, dual degree oral maxillofacial surgeon. And our most recent addition, Dr. Austin Lyman, who trained at MUSC in Charleston. So four of us as surgeons. We also have two periodontists on board that happen to be my own kids. Lindsay is 5 years now with us, and Tony over here on the right side is 2 years. So we have two periodontists, four surgeons, and last but not least is Phil Hedger, our prosthodontist, who does an amazing job, a very methodical individual who really detail is just his bag. So under one roof, we've got an amazing group of individuals. We do have 6 different offices, so we rotate through a couple at a time. And again, as a team, a very impressive group of individuals I've been blessed to have on board with me. I would be remiss if I didn't include in the team my wife of 35 years. Our anniversary was just a couple of days ago. And Diane happens to be a nurse anesthetist, and that's why she's on the team officially. She does the sedations for our many of our cases, especially our full arch cases, of which I'm doing quite a bit of these days. And it's been just a true double blessing to have her double as my wife and our anesthetist, along with her girlfriend, who is also an anesthetist that helps us. In addition, the real joy for us all these days, our grandchildren, we've got 3 of them, and that's been just a joy. Lindsay and Sam, her husband, who is an attorney, but he's a good guy. He's an M&A guy, so he's in that circle of trust kind of thing. But those are the 2 kids here. This is little Ella Sophia, and Andy. She's 4 and he is 2. And this is Tony with his lovely bride, Rebecca, who's a pediatric dentist. And they just had their little daughter, our 3rd grandchild, little Nora Catherine, who's now roughly 11 weeks old, actually. So we're blessed to have 3 beautiful grandchildren. The Institute has been fun. I can tell you that the journey has been a really good one that I couldn't have predicted in any way or form. We're in our 33rd year, and we have more than 400 alumni, all 50 states and 43 countries. It's been fun. And these academic affiliations are, as you see here. The Institute has been a neat one for me, in that I'm able to interface with so many folks from literally all over the globe, and I have thoroughly enjoyed that. One last comment regarding disclosure, and that is, in this day and age, we can grow bone, grow soft tissue, do a number of things at a push of a button, and that's not happening here. Never has, never will. And the images that I'll share with you none of them have been altered or manipulated. They're all of my own cases. So this topic, I think, is a very interesting one, one that is a timely one in this day and age of full arch immediate reconstruction emphasis. I would say so many folks are understanding and appreciating that we have so many patients that we can reach and change their lives, transform their lives, their self-images, basically based on changing one or both arches in their mouth from either an edentulous scenario or partially edentulous failing dentition situation to something very beautiful and certainly permanent. So my charge for this evening is to share with you the end sequence prosthetic protocol that has really been a very impressive one, to say the least. This is the agenda that I will cover with you. We'll have a few comments on history of what the all-on-4 concept is about, which certainly most everybody is aware of, but want to just kind of prep things in building a base for everything to follow. We'll then look briefly at diagnostic treatment planning, what the armamentarium looks like for a fully guided scenario of full arch immediate reconstruction. We'll get right into the end sequence workflow, some case presentations, including video, and finally, some summary comments. So first things first, from a pure historical perspective, where things started, we certainly can give Dr. Brandemark all the credit, no question. This gentleman was quite a visionary as an orthopedic surgeon to have taken what he knew from his orthopedic training and applied it to the mouth. The rest, as they say, is history. So he was doing with his team the work you see right here, meaning a hybrid, as we would call a high water type hybrid fixed prosthesis on typically 5 implants, as you're seeing here. This dates back to the 60s, so pretty impressive in terms of when things really got started. We can give others credit as well. Paul Schnittman, Peter Worley, a number of individuals who really were pioneers in the States to have adopted immediate load concepts. And of course, the all-on-4 concept itself, we'll be talking a little bit about here in just a second. But obviously, we're able to take patients who have either no teeth or, again, failing dentition and apply this so-called all-on-4 concept to them. Historically, we know what this is about now. It does involve immediate function for sure. The so-called graftless approach, I'll talk more on that in just a bit. I think it's a misnomer. But I think the real key is that we're able to minimize our grafting with these protocols for full arch reconstruction. And we give credit to Paulo Malo for really putting this together, the all-on-4 concept, more or less. I did spend some time with him years back in Lisbon, and it was a very fruitful experience, beneficial one to say the least. So the all-on-4 concept is exactly that. It is a concept, and Paulo Malo and Bo Renger again get credit for being the founding fathers of this type of approach, if you will. And as we know, there is certainly a lot of literature that supports the concept. I was a very skeptical one years back, just to be quite honest, about this. But as I began to read and realize that at that time, even there were almost 100 articles published, and these were some of the early ones here, as you're seeing, that Malo and his team published on 98% success rate in the mandible, virtually the same thing in the edentulous maxilla. And then the landmark, as I see it, article that really put, I would say, this entire concept on the map was published in the ADA Journal 2011, and quite an extensive study that involved almost 1,000 implants, 245 patients. And as you see, the success rate of the implants as well as the prostheses, just high 90s. And especially the prosthesis survival rate being 99.2%, 10-year follow-up, et cetera. Very impressive, very impressive. So no question, and I could really reference a ton of different articles, but I think most appropriate are systematic reviews, and these are 4 key ones that really put it together once again with regard to validating this entire approach. And what is the approach? Well, basically, as we know, technically speaking, tilted implants posteriorly in the upper arch to avoid the sinuses, lower arch to avoid the mental neurovascular bundles, and then of course anterior axial implants 2, 3, depending on a number of items that will dictate our treatment planning approach, etc. Immediate load certainly, and the whole idea is engaging basilar bone, as we know, and maximizing bone to implant contact, minimizing cantilever lengths, etc. And of course, the prosthesis is placed then immediately, or perhaps a day or two later. So with that said, the typical approach, the non-digital, if you will, is, as you see here, record-taking appointment could take 1 to 2 appointments. So this analog approach is by today's standards, I would say, somewhat outdated to a degree, although it's done quite a bit still. The workflow on the restorative, as we'll see, is so much different now. But at any rate, treatment planning, and then of course the actual surgery, which is more or less converting a denture into a fixed prosthesis. And this more or less can take conventionally, I mean, traditionally, a good part of a day. Looking at the analog approach on the restorative end with the lab phase, et cetera. So it could be a pretty labor-intensive protocol for 2 arches, for example, 7 in the morning, 4 in the evening, afternoon. And of course, the prosthesis, the final prosthesis, can take anywhere from 5 to 10 appointments. So we're going to see how all of this is shortened, certainly with this fully guided approach. So again, this is a concept we know, but it's more than just key principles. I will say that of all the work I've done and been involved with for my years, and having placed now more than 34,000 implants, thousands of bone grafts, soft tissue grafts, et cetera, nothing really commands more detail, as I see it, on the surgical and the restorative end than these full arch immediate reconstruction cases. The devil is in the detail, no question. So this is not to be taken lightly. Certainly none of implant dentistry should be, for that matter. But of all the things that we're involved with, from single tooth to small bridges, larger bridges, etc., this one really plays on all of the skill sets as I see it, that I've been involved with at least. And that's why I really have enjoyed working with these approaches that we have. We have more than one, certainly we'll talk about, but most impressively and most importantly, we're able to get, apply our wonderful technology for our patients, and the feedback from them is nothing short of spectacular. So it requires a true commitment, a paradigm shift, if you will. And if we just look quickly at a definition of paradigm shift, we know that our viewpoint perspective towards something changes in a rather abrupt moment. We've all had these paradigm shifts in our careers, and certainly this one was one for me. So what we really see is dependent on our perspective. And the whole concept here is what our mind is trained to see. So paradigm comes from the Greek root paradigma, which means a pattern. Now, the pattern that we expect to see with a case like you see, or situation like you see with the middle radiograph, is what you would see on the left-hand side of the slide, and that is sinus grafting, for example, for maxillary reconstruction, 6 to 8 implants for an overdenture, believe it or not. And I was involved with a ton of these over the years. Very successful, I might add. However, the treatment time would be a good 16 months or so and cost quite a bit of money compared to what we can do today in one sitting. So that's what the pattern we expect to see, but the pattern we now see, of course, is very different. And hence this full arch immediate reconstruction concept is one that really has now made all the difference for our patients, for their quality of lives, and for us as clinicians too, with our staff. I mean, the benefit to us is just amazing as I see it. Now, graftless solution, misnomer as I see it. I'm not going to say that I don't do sinus grafts anymore because of maxillary reconstruction involving full arch protocols as we know them. Not true. I do a fair amount of sinus grafting still, lateral wall and crestal. Not nearly as many as I did in past years, certainly. But to say that this is eliminated would be not true. And the same goes with other types of grafts that I'm involved with. So for purposes of this discussion, graftless to me really is a misnomer. And I've said that for a number of years because X number of our cases do require not just bone grafting, but even soft tissue grafting for full arch cases. So the better term by far is graftless. And I think we can all agree on that for sure. Now, with that said, we're familiar with a number of these different phrases, if you will, and what have you. They are all pretty much saying the same thing, and that is there's an analog approach, not just on the surgical phase, but definitely on the restorative phase, where conventional lab work is done, wax rims, and you name it. Conversion denture is what it's all about. So taking, again, a denture and converting it to a fixed prosthesis. If we look at what the definition of a reactive system is, as you can see, it's one that responds to external events, but reacts more or less. And this is the approach that I would say is what the analog approach is all about, more or less. From a prosthetic perspective, we're going to definitely respond and react to a number of things as we find them. And from a surgical perspective, again, we react to the anatomy that we find at time of surgery. Nothing wrong with that per se. It's done quite a bit throughout the country, throughout the world still. But a proactive system would be one that would apply to this and sequence guided prosthetic protocol as I see it. Meaning we are in advance planning so that the virtual plan is enacted through the lab phase of this workflow, and then ultimately to the clinical. So this is a quick collage of what happens for a conventional conversion protocol. And once again, this is what goes on most all the time out there. And it is, again, representative of the analog version of what we're talking about versus the fully guided approach that is, again, more proactive by far. and planned in advance. So at time of surgery, there really is not a whole lot of thinking per se that has to be done because it's so well planned in advance. And we know from literature, there are many, many articles that support the whole concept of having some type of guided surgery and it being more accurate for multiple implant type cases, whether they be in edentulous patients or partially edentulous sites, does not matter. But when there are multiple implants involved, then yes, in fact, we know that guided surgery, be it static or dynamic, is definitely advantageous over conventional freehanding. So with that said, just a few words on some basic diagnostics here. We give credit to Ed Bedrosian for the classification that a number of us do follow, and I like it quite a bit, where the so-called bone zones are identified as you're seeing here, meaning zone 1 represents the premaxilla, cuspid to cuspid, zone 2, the bicuspids, and zone 3, the molar region. So zones 1, 2, 3, we can actually add a fourth zone and call that the zygoma, certainly zone. We can have a fifth one, perhaps pterygoid, etc. But I think what's important is to be able to understand and appreciate when can we apply this fully guided protocol, what type of cases. So what I'll term here, group 1 represents bone present in zones 1, 2, and 3, meaning you have bone across the board, molar to molar. We don't see too many of these folks, I'll be honest with you. And unfortunately, maybe 1 or 2 a year, and typically these folks don't have money. So it's one of those scenarios. Now, group 2 is what we see the most of because we have bone in zones 1 and 2, and hence we can tilt implants posteriorly, have more axial placed implants typically in the premaxilla, and this is what our conventional implant type case looks like in the maxilla. And if we then go on to group 3, this is bone presence only in the premaxilla, zone 1. So here we are more or less mandated to do something different, remote sites of bone, i.e. the zygoma. So these are the so-called hybrid zygoma cases that we do, meaning single zygomas, one in each on each side posteriorly. And then finally, group 4, I call it the no zone. Here, the quad zygoma is the protocol that we follow for reconstruction of these severely atrophic maxillas. Now, with that said, roughly 80% of our patients fall into groups 1 and 2, and these are the patients that we can zero in on and do fully guided via the end sequence prosthetic protocol. 80% of our patients. When we hit groups 3 and 4, that's the remaining group of our patient pool, and they involve zygoma implants. Yes, they can be guided, but that's a different discussion. But for purposes of this talk and the typical in-sequence protocol, we're not going to involve zygomatic implants. Now, armamentarium, just quickly to go through a few comments here. I have a few comments with you, and that is a designated guided kit has to be involved with the implant system that you're working with. And by the way, this is an open platform system, so it doesn't matter what implant type you use. Certainly you would want one with an aggressive thread design, but you must have a designated surgical kit because these drills have to be longer, in that they're going through a stacked system, if you will, of guides. There must be drivers or mounts for the implants themselves, and different designations for depth and planning your case. So the implant system that you're working with should have an aggressive thread design, as I mentioned, and multi-abutments need to be present in order to correct triangulation of the implant placement, especially those that are off-angled. 0, 17, and 30 degree are typical. Some systems have more than these 3. But the advantage of this multi-abutment, of course, is to take the prosthesis away from the head of the implant. And once this is placed, it's pretty much a one-time scenario. We don't remove it. Just a few other items that are, I would say, recommended. I would angled torque wrench and the back action mondure we can talk more about later. But the actual workflow is important, and that is as follows: that this particular workflow is not just involving the surgery, but certainly the prosthetic. So there are 5 recorded items needed under these digital records that need to be sent to the InSequence folks in Reno. And they are as follows. The clinical photos, we'll be discussing these in more detail as well. But this certainly picture is worth 1,000 words, no question. This helps in planning immensely, whether we're going guided or not. Bite registration, full arch impressions need to be taken. And of course, our scan with bite registration in place. And of course, the digital dental lab slip is filled out. All of this is electronically sent to the lab. And then the digital 3D labs data set is merged with the underlying 3D bone structure from the cone beam, and thus resulting in a very complete 3D patient-specific data set that serves as a foundation now for our interdisciplinary team web meeting. So online, surgical-based clinician, restorative-based clinician, and the lab in Reno can be anywhere in the world. Doesn't matter where you're at. Of course, this is an online meeting. And what's beautiful about this is that these facially driven treatment principles can be virtually implemented. And that is the key and the heart of this entire program and protocol, if you will. So that said, you can see that obviously ostectomies can be done in advance. We know virtually everything going on, an optimal setup of teeth, and where implants are placed specifically, angulations, lengths, diameters, etc. And finally, the milling of these of the prosthesis, which is a monolithic PMMA material, and a beautiful one at that, a very strong one that's very, very resistant to breakage. And then finally, lab validation on the lab, and this is a labor of love as I see it. What goes on there is nothing short of, in my opinion, amazing, because the detail is absolutely ridiculous, and it needs to be. So dry model surgery is done, and ultimately what's delivered to us is the prosthesis itself. So with that said, let's go through some cases here that I think will be indicative of what we do with this particular protocol, and how we're able to help our patients. This is Joanne. Joanne was roughly 56, 57 at the time when first saw her. Not real happy with her existing teeth, spaces, some periodontal involvement, etc. And you'll see now how we were able to take her from this left-hand image to the right side with this workflow. So photos, again, are important, no question, to be able to communicate effectively with the lab. And certainly we're able to assess asymmetries and tooth proportions, you name it, different parameters that are absolutely critical to the diagnostic element of what we're doing. And as you see here, with Joanne has a typical collapsed bite, no posterior teeth to speak of, splayed maxillary dentition, periodontal involvement, what we would term terminal dentition. I'm not a big fan of that phrase, but for lack of a better, it is kind of a catch-all term. And yes, in a number of cases, our patients can be treated without full arch approaches, certainly. And we always give our patients these options. So selective extractions, for example, with implants, with endo and perio involvement, et cetera. We present all of this always. But here, as you can see, we're off and running with Joanne. She had opted for full arch work, especially because a neighbor of hers had similar type work done. And she did some homework on it and just really wanted to, quote unquote, start all over. So models, these can be definitely taken conventional, analog, and then they are digitized on the lab end. Goes without saying the value of our cone beam CT. I mean, I've been embraced this technology in 2005, have not looked back. Resulted in an amazing paradigm shift for me, certainly for my practice and for my institute, without a doubt. We're reducing surgical risk and complications. That's really the bottom line here in using cone beam CT. So with that said, let's see what we're able to do here for Joanne. Virtual corrections and additions are done, as you're seeing. In other words, this is a virtual wax up, more or less, of our patients. So you can see existing dentition and then overlaid the optimal setup, more or less. We can evaluate our condyles very effectively with this particular software, very nicely done. And again, the online meeting is just an amazing one. It will take some time at first, I'll tell you that. but I'm going to say that roughly between 7, 8, 10 cases or arches, I should say, later, you're going to become very comfortable with the entire workflow. And we'll talk more on that in just a bit. But this is how Joanne originally presented on the left-hand side. And of course, the optimal setup is on the right-hand side. And once again, we can appreciate the ostectomies that need to be performed ultimately, and the planning of the implants themselves in terms of numbers, specific locations, angulations, lens diameters, etc., both in the maxilla and in the mandible. This planning phase is really an important one. And again, it's done online. And once you're up and running, it's done in less than 10 minutes per case, without a doubt. Very, very fast. So what's important is that initial bite registration, because that is then transformed by the lab into this more hard copy version of the bite that we will place into our patient's mouth at time of surgery, and be able to more or less validate that, yes, in fact, the bite has been all the way through, carried all the way through, and that the lab work that's done by the folks at InSequence is all more or less validated. What's real nice that we receive in our box of goodies, if you will, is this particular treatment planning, virtual treatment planning information that it's quite valuable, because as you see here at a glance, you can tell exactly what type of implant is being used, lens diameters, what multi-unit abutments, 0, 17, degree 30, etc., heights of these MUAs, and on and on. So lots of valuable information is given to us in advance. Here's the planning scheme for Joanne. In this particular instance, 4, 6, 8, 9, and 12 are the implant sites. So on, and even bone density gradients, although we know Hounsfield units are not accurate here with our cone beam CT, but at least we get an idea of a gradient from red to green and everything in between. And the same thing is true for the mandible. So you can see here, we're able to, at a glance, see exactly what implant types we've, or I should say, what specific locations of our implants, angulations, etc. And these cross sections are invaluable to, again, see where things are at time of surgery. So both arches are represented like that. And then this is what typically what the box looks like that you receive. One box per arch for your patient, and very well labeled. And we're then off and running. And this is exactly what we had for Joanne. And I will tell you, at first, this is overwhelming. We have 1 through 19 steps to be followed, and they must be followed sequentially, certainly. Everything is spread out, as you see on the right-hand side. For the first probably 3, 4 cases, I did all of that. I had to. My staff had no idea really what was going on till we huddled a lot and talked and I was able to educate them more. And then ultimately they embraced this, and it's just so easy now to walk in the room and everything's ready to go. They're well trained, well versed. And what's impressive is that this checklist is something that's very, very important, like a flight plan. You don't want to get out of order or you'll have issues. And if you've not read this book, it's an excellent one that been around quite a long time now. But Atul Gawande really puts it in perspective with this particular checklist manifesto that we're able to follow, again, this particular sequence of steps to the T. A very proactive approach, to say the least. So our patients are typically sedated. This is just one regimen that we use. More often than not, we've got our folks with a deep sedation, propofol pump, etc. But either way, they're sedated, and we're then able to verify our bite right off the bat. And of course, we are able to localize our patient, and we're off and running. Now, I'll go through this somewhat quickly with slides, and then share with you some video footage that will make things, I think, maybe put things in perspective a little bit better, and related items that I'll share with you as well. So what's key here with incision design for these fully guided cases is we have to have a more reflection of our flaps. So typical mid-crestal, sulcular, distal oblique release. I'll go back as far as the base of the tuberosity for a couple of reasons. I'd like to harvest bone from there at times. And if in fact we ever needed to place a pterygoid implant, then we're clearly open and ready to go. So at any rate, full flap reflection, serial extractions, and this is something that not a lot of folks talk about, but you really want to take your time here. I don't mean just drag, but be mindful that you don't want to just grip and rip. This is where you want to be very use some finesse and take these teeth out very carefully, as you would anyway, but especially here, because this can impact the placement of the guides if you're not careful. So some tissue trimming, sure. Full flap reflection, typical anatomic landmarks are going to be certainly located and identified. And you must have some type of cautery unit available to you for these types of cases, for sure. I've used radial surgery since 1983, the first year of my practice. This is definitely important. So now here's the key for this particular protocol and workflow is the bone foundation guide. And you're going to see a transition of an evolution, if you will, of what these guides look like back in the day. And here I'm showing you some of the more early versions, and you'll see the more recent ones here soon. But the key of this bone foundation guide, and by the way, it's a very appropriate term, because what it does is it serves as a foundation for other elements, other items that are going to be stacked onto this foundation guide. So one key step in this whole protocol and this whole workflow is seating this foundation guide accurately with the so-called struts. As you see here, there are 3 struts with this particular version, and they even have a couple dots, and there's some screws. I mean, again, an earlier version. And in order to seat the foundation guide, these struts are there so that the mantle will be auto-rotated, in this case for the maxillary arch work, and keyed. And only then would we drill the holes and certainly fixate the that foundation guide. Then the struts are removed, as you're seeing here. And by the way, this is all done on your articulator. We have to use the Panadent for a number of years now. And this is the second iteration of the mono strut, as you're seeing right here, with the actual teeth. So, and all the struts are more or less united to the teeth. So hence the term mono. Now, when the foundation guide is in place here, you can see the actual bone segment matching the amount of bone that's visible that has to be reduced. So from a bone reduction perspective, this is a no-brainer. You just literally take this bone, and between a back action rongeur, round fissure burr, you can get right to this point rather quickly. So proof of concept from virtual to lab to clinical is really straightforward. I mean, it takes no time. The reason I use the back action rongeur to start is I harvest that bone and will use it for grafting, perhaps as I need to later. And then now the surgical guide is placed or indexed onto the bone foundation guide. The surgical guide, again, acts as the main indicator or guide, if you will, of and for your implant placement, certainly. So then a series of keys are used with the drills. And of course, every implant system has its own type of key and drill sequence, etc. And as we know, to improve primary stability, we will under-prepare osteotomies. Typically, the macro geometry, especially of the implant design, is critical. The longer the implant, the greater the bone implant contact. And certainly, we have a new fell on the block, so to speak, and that is osteodensification. It's been some 6 years now for me that I'm able to use these more so when I'm freehanding the surgery. So at this point, these mounts, again, depending on the implant type you're using, these mounts are either have a flat end like this or a dimple, but that needs to be lined up with the so-called blue line on the surgical guide, because once this mount begins to touch the master cylinder of the guide, maybe one little extra turn to get it to the next flat side, in this case, or dimple, to line up with the blue line, gives you the depth element to your implant placement, which was pre-planned, of course. So here you're seeing all 5 implants placed, the 5 mounts are there. They will get unscrewed. And now the surgical guide is disarticulated, showing the implants, again, virtual to lab to clinical. And at this point, milling of bone is done as we would normally do for freehand conversions. And the multi-unit abutments now are placed one by one, and the prosthesis is tried in one at a time I should say, with each placement, with the placement of each multi-unit abutment with the handle to make sure that we have draw. And that's important because you may not get draw totally, and you may have to open up one of the holes a little bit more. But again, things are very predictable here. The gasket is next placed, is the next item placed onto the foundation guide. And this gasket acts kind of like a rubber dam, more or less. We place our copings that used to be pre-cut. Now they are pre-selected, but they have two flat sides, and it doesn't really matter which flat side is to the facial, but one of them needs to be to the facial. And as you're seeing with this iteration, a bite index is important to seat the prosthesis. So in this case, we'd have to auto-rotate the mandible, get the bite real good, and only then would we be able to utilize our luting agents to pick up the prosthesis. And again, this is what typically a typical prosthesis would look like. And we prepare it with appropriate lubrication, bonding agents, etc., so that we can selectively allow that flowable composite to do its thing, so to speak, and literally wrap around those copings and be able to pick up the prosthesis. So that is then removed from the mouth. And at this time, or one time I should say, a clear bridge, as you're seeing here, would be then placed back in the mouth and picked up again with this separate set of copings and straws and blockouts. And this could then be used later, as would show you, in preparation for the final prosthesis. So this is the workflow, in fact, that's would be done then. After 4 months, for example, we would remove the long-term provisional and then just allow for some space under this and seat that duplicate bridge, radiographs to make sure, confirm the seating is good, evaluate aesthetics, etc., and check occlusion, of course, index, and then, of course, final impression, which would be done with typically a PVS medium body type material that's syringed in there, etc. And then finally, this duplicate bridge is then sent to the lab with the impression, etc. And the prototype setup for try-in can be done at the second restorative appointment. And then finally, if there's even needs to be a third, typically there are 2 appointments, the final prosthesis is then delivered. So a real nice way of going about things. Instead of that clear bridge, this is what we have now, meaning 2 long-term provisionals rather than a clear bridge. So one the patient has in their mouth, the other that you have stored until they come in for that final approach, or final prosthesis placement. And these are the appointments that are eliminated with this particular duplicate LTP bridge, if you will. And you can read very nicely. And this is why, instead of having 5 to 7 restorative appointments, typically 2, and you're into a final prosthesis. So back to Joanne's case here, we're going to bone contour, as we've talked about, do some grafting. And then, and by the way, grafting is important. Can you imagine? We're going to have case situations like this where you have threads exposed, or pathology has eroded bone away, even some cases plates, etc. So that grafting with true membranes and fixation are important, in my opinion. So again, you know, the graftless versus graftless, no question, we know what that's all about. And of course, soft tissue closure. And while this is happening, the mandibular surgery then will begin. And the prosthesis is now being more or less, we call it a refinement. It's not a conversion, obviously. It takes about 20, 25, maybe 30 minutes, depending on the situation. And as you're seeing here, the prosthesis is very well done, delivered to the mouth, placed into position. And at this point, we're, of course, addressing the mandibular arch, where we do the same basic thing. The local anesthetic applied, certainly. Our incision design is to the retromolar pad with distal oblique release incisions, and identifying appropriate anatomic landmarks as we would normally, extracting our teeth, etc., all the way through to final prosthesis, meaning we're able to use the same foundation guide concept and picking up the teeth ultimately, etc. But here, the bone reduction, just like the maxilla, it's identical. And we're able to very nicely contour that bone, make it really flat with the foundation guide, the surgical guide, which you're going to see different iterations coming up than what you're seeing here, but the concept's the same. That surgical guide has to be seated quite well against the foundation guide. And then ultimately these keys, as we know, with the appropriate drill diameter, are used sequentially to create our osteotomies. Implants are placed, the mounts are removed. And again, just like in the upper arch, ultimately the prosthesis is placed. So before that's done, though, we have to, of course, mill our bone, graft any defects, etc. And the copings with the gasket are placed. Everything's the same, appropriate grafting, as we've mentioned, and primary closure. So the refinement now of this lower prosthesis is done. And we have our interim prosthesis, as you're seeing, and we're able to light cure this. And at this point in time, we will have delivered both the upper and lower prosthesis together for Joanne. Now, without photography, without video, etc., a case like this can easily be done in 3 hours, 3.5, just depends on. It's not a race, by the way, just moving in sequence quite nicely. Certainly we can run into glitches sometimes in teeth that are rather ankylosed, etc. But for the most part, we can move quickly, and what would take normally a full day can be done in certainly 3 to 4 hours upper limit. So this is what's delivered for Joanne. And if we just quickly look at the video for her, just to get an appreciation for what does go on. At least this is now an 8-year-old video, so keep in mind the prosthetic, I should say, the guides that are used. Here we're drilling and showing you the fixation of this bone foundation guide with these single struts, and they were a bit of a nuisance. I'll tell you that, because they were screwed in for one, and they were single rather than connected, i.e. the mono strut that followed. So the next iteration of the entire strut design was a mono strut, as I showed you briefly with that one picture. So at this point, we would remove these screws so that the single struts would be taken away. They've served their purpose to seat that foundation guide. That's critical. This foundation guide literally is the foundation for everything that follows, because if that's not accurate, then everything that is done from that point forward is accurately inaccurate. And of course, not a good thing. So again, just for sake of time, here we are. We've done the ostectomy, the alveoloplasty, smooth things down with that large fissure burr. And at this point, the surgical guide is in place. Let me go back here. We're drilling and undersizing, of course, as we would normally, especially in the posterior maxilla, but ultimately placing our implants through these master cylinders. And again, lining up the blue line with the appropriate aspect of each mount. So we know we have appropriate depth that's been pre-planned, like you're seeing right here. Okay. So at any rate, we're able to now do some bone milling once the surgical guide is disarticulated, and we can then place the multi-unit abutments right after this milling. As you're seeing here, one by one, and check with the prosthesis in and out, so you know if you have to open up a hole, you can do that, widen it at all. And here you're seeing we're doing that one at a time. Otherwise, if you put all of them in and then try to place your prosthesis and it won't fit, you won't know which of the multi-abutments needs, or I should say, which of the holes needs to be widened. It's just not a good situation. So one by one. And then ultimately, we're able to place the gasket and copings as we've talked about. And very nicely, you can see the gasket secured well. These little straws, block out, are placed within the cylinders. And of course, the prosthesis is prepared, Vaseline, so we don't get pickup on the intaglio surface, but we also do place a bonding agent on the inner aspect of those holes. So that then this is the pickup as it used to be. I'll show you the more recent iteration here in just a bit, but blockout straws are there, etc. And this is just using the clear guide, which again today would be a not done, but the soft tissue closure now. And of course, we can go to the lower arch and do basically the same thing where we've extracted teeth after our full flap reflection, both facial and lingual. And we're able to, keep in mind in all these cases, I'm showing you complete edentulation. The latest iteration is keeping a few teeth to act as stops, as we'll see. But at any rate, there's our bite and registration. There's our surgical guide being placed. Our osteotomy is completed. And once again, the implants through the guide. So everything is done in advance. So there's really no real thinking per se. And by the way, you will have rehearsed all this in advance of the surgery. So I strongly suggest that at least a few days, if not longer, even a week before your surgical date, you sit down with the kit, open it up, place the models onto the articulators and go through a dry run with your staff especially. And in essence, you're like a flight simulator. You will have done the surgery already. So it's kind of second nature. The brain doesn't understand virtual versus reality. So when you're actually doing the surgery, you've done it already. And that's kind of neat. So here we are with Joanne, and ultimately, you'll see that the upper and lower prosthesis has been seated and secured. And once again, this can be done in a relatively efficient manner and a very time-sensitive manner. So with that said, this is a 1 month follow-up. 7 months, or typically at 4 months, we'll convert over to our final prosthesis. But here with Joanne, between her schedule and ours, we didn't quite collaborate till a bit later. But our typical final prosthetic sequence here, as you see, would be just labor intensive, and no need to go through all of this analog approach. It's just very really not necessary and labor intensive for sure. Like just a lot of time involved. It doesn't have to happen. So here's Joanne, 7 years out, and really has done extremely well. One of our many ambassadors for our practice. Just very happy. Zirconia upper, acrylic wrap on the bottom. And this is what we have 7 years out, actually almost 8 years now, and a very happy patient, needless to say, without a doubt. So just shifting gears to a different patient now. Virgie represents a similar type of situation, except only single arch that I can just share with you that will dovetail into what we do now today, which is something different in terms of the specific workflow and items. But at any rate, you can see Virgie has some issues in terms of a canted occlusion and collapsed bite once again. Lower dentition, not bad. Very good for just new restorations. Very stable, healthy periodontium. But the upper, as you see, some issues, periodontal involvement, some endo involvement, you name it. And once again, Virgie was just flat out wanting to have a new set of teeth up top, start over. Was tired with typical back and forth with all the routine appointments and not getting a whole lot done and having things fall apart, et cetera, et cetera. So virtual treatment planning, once again, is just a beautiful thing. So you can see here the ostectomies again performed, and this view is invaluable, where when we do go online, we're able to see quite nicely where the implants would be. The emergence profile certainly very nicely distributed, or AP spread, minimizing any distal cantilevers, if not eliminating them, certainly in our provisional prosthesis, etc. And of course, these cross sections are invaluable. And this is at the heart of our online meeting in terms of actual placement of the implants in specific locations in terms of length, angulation, diameter, etc. So here's Virgie with edentulation of the arch and full flap reflection, the bone foundation guide again being placed, indexed, and fixed So at this point, these single struts again are removed, and this is what we have. Again, proof of concept, that bone segment is equal exactly to this plastic segment, if you will. These are identical. That's how precise this protocol really is. So we can now do our bone reduction, place the surgical guide, and again, using a designated guide, surgical guide kit for full arch work. You're seeing, of course, the osteotomies on the left-hand side being done, and of course, the implant placement through the guide. So everything is completely guided, surgery and prosthesis. And of course, now the surgical guide removed. Once again, multi-unit abutments placed, and the prosthesis, just trying kind of getting an idea where these holes are. And one by one, remember, with multi-unit abutments, we're trying in that prosthesis. The copings, and of course, on it, just as I shared with you earlier, the dual cure flowable composite pickup. And at this point, we're grafting our sockets, any particular residual sockets, pathology created, any bone defects, etc. Or if we're even thinned out and have a very thin facial plate, we'll want to veneer graft that for sure. And of course, refinement of the prosthesis is then occurring. You don't need a lab technician, by the way. This can be delegated to one of your auxiliary for sure. Really not that difficult to do. And of course, the prosthesis is then placed. Now, looking at a little video clip of Virgie, we can again kind of go through this in a little bit more summary form. And I can narrate, of course, over this. We, of course, are going to take out our teeth after our initial incision design. You can use retraction sutures, as I'm showing you here with Vicryl, for example. Use Forto Vicryl, large FS2 needle. You want good clearance. You're going to be a little bit more aggressive with flap reflection in these arches than you would for conventional conversion type cases. But again, what we've shown you before, that foundation guide has to be placed in an accurate manner. And when it has, those struts, of course, are removed. And now our bone reduction is occurring, as you're seeing here, quite nicely. Surgical guide is now placed onto the foundation guide. And there's our key for each diameter, of course. Undersizing, as we all know, appropriately, especially with our posterior-based implants. And now the implant going through the guide. And these little plastic stops for this particular implant system, predetermined placement. So therefore we know the length. And as soon as this little clip would touch the master cylinder, one little extra turn and we're done. So our partial rotation, basically. Again, we're removing the surgical guide at this point, the mounts and the surgical guide, and do our appropriate bone profiling. And at this point, we have 5 implants, as you're seeing here, placed. The multi-unit abutments then follow. And by the way, there are marks to designate exactly where that fixation screw needs to be, so that in essence, the timing of the specific 3D location of that multi-unit abutment is already predetermined. So it's real simple to just place it and not worry about back and forth and maybe 17, maybe a 30, maybe greater, etc. So they're all pre-selected, and that's a part of the plan, of course. So once again, the try-in. The coping is now placed one by one. And once that's done, then of course we're able to place the gasket. Again, serves more or less a block out like a rubber dam. And the block-out straws are then placed into the copings. And here we did use a bite index at that time to register and make sure that we're in the right plane, and that most importantly, that the prosthesis is seated correctly. And only then do we pick it up, this dual cure flowable composite. Again, this is done very efficiently. And once your team is used to the flow, it's just a very beautiful one. It's almost like a symphony. Everything just kind of flows, and I mean, barring anything unforeseen that certainly can happen, it's very unusual. We just kind of move through this quite well, quite efficiently. Here's grafting. PRF, used bioactive modifiers since 1998 with PRP to begin with, and then another first generation bioactive modifier, PRGF, and then finally PRF for the last probably 12 years, which is, as we know, a second generation bioactive modifier that upregulates VEGF and increases angiogenesis nicely. So here's the prosthesis being placed for Virgie. And these little screws get torqued to 15 Newton centimeters typically, closing up the holes. And there's the occlusion. And I'll tell you what, the occlusion is so accurate with these cases. It's amazing. Our dual arch cases, you would think there'd be issues. So we started with this with Virgie. We, of course, full flap reflected, placed our foundation guide, did our bone work reduction, placed the implants, placed the multi-unit abutments, the copings, and of course, the straws to block out. At this point, we're able to pick up the prosthesis, graft, and then place the prosthesis. And another happy patient, of course. So this is now a few weeks later for Virgie. And during this time, of course, we're monitoring our patients. Sutures are resorbable. We don't worry too much about them, using chromic suture. And again, a 7-year follow-up, just very, very predictable. Back then we were using zirconia upper, acrylic wrap on the bottom if we were doing both arches. Here, of course, natural dentition. And you can see crown bridge where conventional was done for her in that lower arch. Proof of concept, you always want to have, of course, cross sections to make sure that you have good marginal bone stability in your cases as you have them come in for recall. Very, very important. Now, with that said, what I'd like to do is just share with you a more current video representation of what we do in terms of what's available to us with the N-sequence protocol, because it is different now, and it's there's some pluses, I would say. Yeah, absolutely. So we're just going to shift to the let's see, we're over here, right to, where is he? Yep, perfect. So this is really a video that we obtained during one of our recent full arch courses. We do live surgery for all of our courses. And this is one that has been edited, yes, but very indicative of what's available to us now. Because what I want to really emphasize here is the utilization of a different type of foundation guide, one that's metal versus plastic. And I know metal's been used by other companies certainly over the years, but this iteration is really an excellent one for this particular protocol, because it does minimize the amount of reflection of tissue, for one, that needs to be done, and then secondly, acts as a more stable base as a foundation guide for what follows, as we know, which is our other guides, or I should say other surgical guides and related items. So here we are, incision design once again, mid-crestal, sulcular. But what's important here is that we're going to keep some teeth. We're not going to edentulate the entire arch as I've been showing you, because this protocol mandates that we have some tooth stops, which in turn means we don't have to, for a maxillary case, auto-rotate the mandible and have the patient in occlusion in order to pick up our prosthesis. Just makes all the sense because we have the teeth as reference points. So this will make more sense here in just a bit. But in this particular patient, Adam is his name, we're able to very nicely reflect our flaps, as you're seeing here, and use retraction sutures. This is a real advantage on the facial and the palatal for that matter, where it's like having extra assistance. So just vicryl suture will allow you to take that flap and get it out of your way, typically a couple sutures each side, maybe one midline, and it's just having the entire facial flaps moved out of your way, and then typically two for the palate, and we have the palatal flap now reflected. And again, being conservative with our tooth removal, we can remove some bone without affecting that foundation guide. Got to be very careful because when that foundation guide is seated, several things can happen that are not good. And that is, number one, if you've not had enough reflection of your flap, then you're not going to seat the guide. Number two, you may get some of your flap trapped under the foundation guide. And then thirdly, you could widen your alveolar ridge if you're not careful in taking teeth out. So those three things can cause you grief in terms of wanting to just passively seat that foundation guide and be done. And that's typically what does happen. It doesn't take long at all. But if any of those three items I mentioned occur, then you're going to wrestle. So you need to identify the problem and solve it and deal with it. So here we're just taking some teeth out, and ankylosis of teeth is never fun. We'll root bank time to time, even do some socket shield application depending on the specifics of the case. But here, what I want to show you is, and I'm just going to stop this for a second. Let's see, we can pause it. Boom. This is the metal foundation guide, and this is the monostrut that fits over it and will be secured with some plastic pins into that foundation guide. So we're going to show you that now, like this. It kind of looks, yes. So we've got the monostrut now secured to the foundation guide, and that foundation guide can only fit really in one place. And by the way, let me back up. It's tooth supported and bone supported. So as you're seeing it being placed, we've kept some teeth, yes, and there's some stops built in, of course, to the underside of this monostrut. And once the contact has been made with the strut to the teeth and vice versa, then we know we're good in terms of 3D placement of this foundation guide. We'll also look for different bone stops, posteriorly in particular. So there's several check and balance scenarios built into this system that make it very, very nice and predictable. So you almost have to really want to screw it up to really have issues. So at any rate, the foundation guide with this monostrut is now in place. And again, you see, we're not having to auto rotate the mandible, not at all. It's just secured to the teeth. So we drill our holes, we place our fixation pins, and at this point, the job of this monostrut has been done. So we want to remove it. And it's just easy to take these fastener pins out, as you're seeing here, not a big deal. And one by one, and now these remaining teeth can come out. In this case, it was a bridge. So we can extract these teeth, do our alveoloplasty, and we're off and running with the next phase, which would be what? A surgical guide, of course. So here again, just edentulating the arch, doing our alveoloplasty. This large round fissure burr I like a lot from Brasseler. Selvin has carried this forever. And then here is the proof that we know we're good with the bone reduction, meaning just take a perio probe and go across here and make sure that everything is flush, meaning the actual metal here of the foundation guide with the bone, all this is flush. And it needs to be, because otherwise, think about it, the surgical guide that follows fits intimately against that. And another way to verify that you have bone reduction is this little guide that is termed a multi-unit abutment angulation guide that gives you even better proof or verification of where your multi-abutment should be placed. I don't typically use it because the marks are already on the foundation guide. So here is the surgical guide now being placed again with the fastener pins. So you can see now that everything has been pre-planned, so you can't screw this up. You really can't. Appropriate drill diameters are utilized. And of course, principles that we use from conventional freehand surgery are applied here. And this is so important to really talk about just for a minute. And that is that if you're going to do guided surgery, you really, really need to know how to do conventional freehand surgery. And there's a couple of reasons for that. One, the principles are identical, meaning what we do on the brain guided surgery, more or less, to fully guided, very similar, meaning we're looking for remote areas of bone, good basilar bone. We're tilting implants and all that good stuff. But most importantly, are the incision designs, things like that are so similar. But also, should you have an issue with one of these cases, and it can happen, where you just have spinners and you don't want to put this patient into a denture. So one or two of your posterior based implants just don't have good torque values. 30, 35, we're after. We'll pick up some that are even less in insertion torque. But what I'm saying is we may have to shift gears and perhaps even abandon the guide altogether and now freehand. So what would you do if you didn't know how to freehand surgery? Meaning perhaps a different, even different diameter implant could be used in the same hole. That's fine. And we'll do that time to time. But what if you have to go to the pterygoid or even zygoma? Then all bets are off, and now you're going to take that denture and convert it, and why not? So at any rate, knowing how to do brain guided surgery before fully guided is absolutely, before any guided surgery for that matter, is very important in my humble opinion. So here again, we're just seeing a series of drills being used to a good irrigation, by the way, absolutely critical for any guided surgery. Good irrigation and good pumping action back and forth with the drills, because heat will build up certainly within the master cylinder. Here, implant is being placed. You can see this little clip for this implant system is what is used to gauge the appropriate depth of the predetermined depth that you've already planned for the implant itself. So when that plastic sleeve just begins to touch that master cylinder, we just rotate ever so little more, and we're there, et cetera, et cetera. So here we are again, all the implants in place, taking out the mounts that were threaded into the implants. Keep in mind, you can't just place the implant conventional through all this stacked system of a series of guides. So you need a mount that will act as an built-in extender that allows you to place the implant to depth. So now the mounts are removed, fixation screws of the surgical guide, or pins, I should say. And now so this proof of concept, what we're showing here, get back up here just a second. This is really important. What we're showing here is there's the model. And these printed models are invaluable, by the way, for planning and looking. As I said, you're simulating the surgery as you go through the using the models mounted onto the articulators, appropriate guides, et cetera. You're simulating the surgery. But this is proof of concept for sure, because you've got the model with the dummy analogs in place, and this is exactly what's in the mouth. I mean, there's no two ways about it. It's identical. So again, the detail on the lab end to me is just mind-boggling. So here we are. We've got everything validated in terms of implant placement. We're going to do some milling, remove the bone around the implant bodies. And now, as you see, we're placing these multi-unit abutments one at a time. And this is that multi-unit abutment angle guide, which to me is a bit of a nuisance, quite honestly. I don't care for it, but it can be used. Again, the marks are already on the foundation guide, so I don't really play with it. At this point, we want to verify that with each coping placement, remember, we're going to place the multi-unit abutment in the small handle. We're seating the prosthesis, and see, you might have a little bit of a area that has to be relieved. So you'll know that one by one before you go to the second and the third, et cetera, implant site. So you see the flanges on that hybrid prosthesis. You're going to ultimately secure that to the foundation guide. Those same holes are used all the way through. Here are the copings once again. Back up here. Yeah. So you can see nicely the vent holes are made in advance, and may have to open them up a little bit, but we're just applying now our appropriate adhesive so we can pick up the prosthesis. Now we've blocked out the holes, and it just flows nicely. You can go directly into and around these copings, certainly. Just a really nice way to do this. Get a bite index, and then unscrewing the prosthesis, as you're seeing here, quite nicely. Just a very, very nice way to go about this. So predictable. And now this is finally when the foundation guide comes out. It will have done its job to this point, since the prosthesis is picked up, the pins are removed, and there's that metal foundation guide. So at this point, the refinement of the prosthesis is happening, and I'll just go through this rather quickly because this is what's done. Now for our live surgery case course, which this was one of, as I mentioned, the live surgery case during one of our recent courses. There are two cameras happening at the same time, meaning one video camera is on the prosthetic end, as you're seeing here, where Philip, our prosthodontist, and Carl Magyar, who's also a general dentist of 35 years plus that I've been involved with, the two of them are doing the work on this end as part of the team for our courses. And then I will be closing at this point at the same time the maxillary arch, and so there's a video camera on me, but this is what's done here on the refinement end, so to speak. This quick up is used quite well, and able to just go through this well and predictably get appropriate pinks and whites. There's a repair model, very, very quickly done. All this less than half an hour, and before you know it, it's done. I will have been pretty much closed or close to finishing on my end. I should be done most all the time. And at this point, once that prosthesis is refined enough, I'm again securing my flap margins. This is a chromic suture. I used FS2 needle, a series of mattress sutures and continuous interlocking, and we'll get everything closed up rather nicely. And at this point, we'll take that prosthesis and remove the healing abutments and place it, secure it, torque these screws down 15 Newton centimeters, checking the bite, and a little bit of occlusal adjustment, our little plumber's tape going in, and then we block out and secure these holes very nicely, very conveniently, very predictably, and the bite is perfect. The lower arch will be done with this gentleman as a phase 2 treatment. So at any rate, back to our case presentations. That, by the way, that what I just showed you is the most recent iteration of what we're doing in terms of what's available to us, meaning that metal foundation guide versus the plastic is just a really step up for sure. And it's number one, it's a lower profile foundation guide. So therefore flap reflection, especially on the palate for the upper, doesn't have to be as aggressive, and even on the facial for that matter. And then the same thing would be true in the mandibular arch. Not as much lingual as well as buccal or facial flap reflection needs to be done. So that is, again, one of the more recent videos that we have to show that workflow and what the more updated, most current iterations of these guides are all about. So with that said, want to share a final case with you, as well as wrapping things up with a video that will compare both animation and the actual clinical realm side by side of this entire workflow. And I know there's some repetition here, but it's important. Those of you who are not familiar with the system, it may still seem rather complex and too involved, but quite honestly, it's not. It really is not. And here you'll see this patient. I typically fool a lot of my course attendees by asking, who do you think this is? You know, and more often than not, I'll get an answer that's to me at least, kind of obvious, I would say, because when I see this picture, I think of Hulk Hogan all the time. So typically someone will say, yeah, Hulk Hogan. And I say, well, he lives actually in not far from us here, but the reality is this is Ed from the Bronx. And Ed is a neat fella who really had dentures but didn't wear them, hated them, just was very depressed, just would hide his smile, hide his face, when his lips when he would eat and talk, et cetera, et cetera. So the long and short of it is, when he did come to us, we were able to explain to him what could be done, full arch reconstruction, et cetera, immediate. So we made him some dentures, as you see here, some fiduciary marks and markers, and at least that's how we did them at that time. So this is about 8 years ago, almost 9 years now. But this is a case that I want to share with you only because it's one of maybe two, honestly, that have done flapless. I'm not a big fan of flapless surgery. I am not. And big reason for that is that there are discrepancies at times from our cone beam CT to clinical. So you only know that intraoperatively when you flapped, and there are things there that a little bit different than what you thought, et cetera, et cetera. Plus you have to have a fair amount of bone volume to do this, and certainly attached tissue. So combination to me isn't a good one to have to be optimized so much. So even our full arch, or I should say our edentulous arches, if I'm using a fully guided approach, I like to flap. So, but for sake of time and being able to just cut to the chase here with Ed, I decided let's go with, because he had, as you'll see, division A bone in both arches. Let's go with a fully guided approach. Cone beam workup, very straightforward, and we're able to see in cross section he had abundant bone to work with. So the dentures now were scanned, digitized, and here you can see the diagnostic dentures and beautifully done. And this is the optimal setup for him. And you know, there's Ed's upper and lower in a really ideal occlusion, of course. So, and also going a step further to really, you only use 4 implants. Now, I'm not a big fan of just a number 4. I think most people are in the same boat, more or less. You know, we treatment plan on the basis of a number of parameters, not the least of which is male versus female. For example, we know that our male population is going to be stronger bite in general. Pair function, of course, plays a huge role. If we can place more than 4 implants, I certainly will. I could, again, depending on the bone we have available, et cetera. But for him, I just decided let's be puristic and go with 4. Typically, I would have at least 5 here for sure. Either way, the plan is, as you're seeing here, and when you have an edentulous upper versus lower, these guys, and if you're doing flapless, utilizing a flapless approach, then you're going to use what? A soft tissue based guide, not bone, not tooth, which are the more accurate ones as we know. So here you're seeing 2 guides, soft tissue based with a bite index, and fixation has to occur simultaneous, upper, lower. Then of course the index is removed, and in this case the lower surgical guide would be also removed, and we're off and running in the maxilla. So trephines, of course, are used to remove tissue, and we're then, of course, creating osteotomies as we've been showing you, so that there's nothing really different there. And we're then ultimately able to place our implants through these master cylinders as we've shown you. Appropriate torques, we certainly like to have a 30-35 Newton centimeter torque per implant site, but then the so-called composite torque value that a number of folks talk about plays a role to a degree. Nothing really scientific about that, but the number 120 has been tossed around for quite a few years, and I think Goldie Jensen is credited with saying that to begin with, meaning that if you have a composite torque value of 120 for the whole arch, you can pick up some of your implants that may have only a 20 Newton centimeter torque value, et cetera. At any rate, here we're seeing that all 4 implants were placed through our guides as we planned in the upper arch. And at this point, we are able to shift gears, go downstairs, and utilize the same basic protocol. We're able to punch through. Here we don't have a lot of attached tissues, I'll say that, and that's one drawback to this flapless approach. Here we have to actually take some tissue away from the upper arch in order to make room for seating of the the prosthesis itself. So at this point, we're just showing you the long-term provisional bridge for each arch, and didn't take much work to certainly adjust this occlusion, as you can see, rather quickly. And there's a 2-month follow-up. And by the way, again, no photography, no videos. Can you imagine the short amount of time for a flapless case like this? I mean, it's almost absurd time-wise that's spent, certainly. Very predictable, I might add, of course. But at any rate, back to Ed, here we are with important that soft tissue gap be addressed, because at times patients will complain of either food impaction, possibly some speech changes, etc. So that can be done. Typically, we would use triad, although now my understanding is that's really not available anymore by Dentsply. It's unfortunate, because I had a lot of use for it, as I've learned from our restorative-based colleague, Carl Magyar, who really, I think, put triad on the map for Dentsply. I collaborated with them and showed them 15 different applications for it, not all implant related, by the way. At any rate, other materials are available, of course, to us to do the same thing. And then ultimately, here's 4-month follow-up, as we see for Ed. And now he's trimming his mustache, and may not be exactly symmetric, but better than what he started. And again, we're able to see the cross-sectional views of these particular implants. And that's the only way we can verify that we have adequate marginal bone stability, especially long-term, is to follow up with our CBCT, and then you utilize these views to again validate the bone that's there. Again, 8-year follow-up for Ed. Zirconia upper at that point in time, acrylic lower. We then, I'd say the last 4.5, 5 years, wean more into nanoceramics that we use today, and even more into a little different situation in terms of materials. But nanoceramic has been a workhorse for us for some time. And again, there's our follow-up radiographically for Ed. I'm going to share with you a little video clip that that we have from him. He's a very articulate gentleman, unscripted. This is just all spontaneous, really impressive, which you'll hear from him.
When I was in the Army, the idea of a dentist was, I guess, different than what civilian dentist is. When you go to a civilian dentist, they actually try to repair your teeth. When you go into a service dentist, they just pull your teeth. So I made do with having lack of teeth by chewing on one side of my mouth. All the tricks. Anybody that loses teeth knows all the tricks that you can do. So growing my mustache was a way to disguise it. And then I found out about implants, and I came and I seen Dr. Picos. I got them now, and I'm very happy I got them, you know. You can even taste the food so much better when they're implanted, you know. Everything's changed. It's changed for the better. I can smile. I can actually cut my mustache off. But I cut it up a little high now to show the teeth. I'm not trying to hide them no more. I felt normal. Like 3 days later, there was no pain. It was nothing. It was unbelievable. And I just would have never even considered it until they showed me this new way of doing it. And I'm like, man, that sounds pretty good, you know. People that enjoy eating are going to love having them because they're rock solid. There's no movement in them. There's no movement in them whatsoever. There's no pain. There's no taking them out. I think I had 4 holes drilled on the top and 4 on the bottom. And it was like one day of Tylenol painkillers, and like the next day I was fine. Pizza was very, very different. If you don't have bottom teeth that are anchored, you can't eat pizza. about 3 days after I had the operation, I got a pizza. And I was like, all right. But man, when it really comes down to it and you really get hungry, you really need those teeth to eat. And these allow me. I can eat anything. There's nothing I can't think of that I can't do now, you know? Before I couldn't even, like, when you wanted to rip tape something up, you grab it with your teeth. You can't do that with dentures, because the dentures will fall off. But with these, you can actually grab, not that you're supposed to. No, I feel that I can smile now instead of hiding it, you know? A little more confidence in my teeth, you know? No swelling, no nothing. I mean, this is great. It was absolutely fabulous, you know? It was the best dentist experience I ever had. It's so easy. Nobody should be afraid to do it, you know? If you got dentures in your mouth, you shouldn't be hesitant. It's very simple. She's still married to me. I feel good. When I was in the Army.
So a couple of things came out of this. One, him eating pizza within a couple of weeks of having the teeth was a no-no. And I didn't know this, of course, till I saw the video itself, which is kind of comical. And then, of course, him talking about duct tape and tearing it. I mean, gosh, that's the last thing you want our patients to do. But this gentleman turned out to be an amazing fellow for us, a great ambassador for the practice, no doubt. Has sent us quite a few patients over the years. But just indicative, again, of what we're doing for our folks. I mean, just an amazing, just amazing what we can do from a single tooth situation, certainly to full arch, but full arch patients, full arch cases in general are the most rewarding. There's no doubt about it. What we're able to do with our technology today is just nothing short of amazing. So I want to show you in summary an animation on the left side that was done in-house by our own IT fellow, Roger Heeman. And on the right side, the actual surgery. So you can see at the same time what's going on. This kind of summarizes things. And again, you know I've covered this several times now with the videos that we've shown you, case studies, etc. But this kind of wraps things up. Again, not with the most current foundation guide. Yes, we'll need to update this, the entire video itself, but I think puts things in perspective rather well in terms of the workflow. And I can't emphasize how much work is involved on the lab phase of what has to get done. It's just amazing to me. It is, whether it's a single arch and certainly a double arch case, just absolutely over the top in terms of accuracy. And this is the key here, because if this entire technology did not result in a very accurate situation for us, meaning predictable to place these prostheses well, etc., then it certainly wouldn't be worth our time and trouble to even think about it. So at any rate, here we are with the again, the importance of this bone foundation guide. Cannot stress the importance enough of this, because this must be accurately placed onto that alveolar process, whether we're using the teeth as stops or eventually in the arch. Both options are available to us, but either way, this foundation guide must be accurately placed onto that entire bony alveolar process and secured well, because again, from that point forward, everything follows. So if there's one step that's critical throughout this entire sequence of events, so to speak, it's this one right here. So back to the animation and the clinical. So here we are, again, securing the foundation guide with this monostrut. And in this case, we're still using the bite of the lower arch to secure that foundation guide in the right place, right orientation. We drill our holes, we place our pins, and now what we have here is, as an end result, the foundation guide securely in position, and these fastener pins again are removed. The monostrut then comes out, and it will have done its job. We're done with it. So now we can address the bone, of course. And I like this back action rongeur to harvest this bone and use it for grafting purposes. Why not? And then finesse it with the large round fissure burr, which has been a workhorse burr for me for more than 35 years. Gosh, I'd be lost without it. So here we are, just contouring, finessing the bone right down to the area level of the foundation guide. And now see, the surgical guide is actually keyed into the foundation guide. You can see those little slots and keys, more or less. At this point, the surgical guide is secured with these fastener pins. And one by one, again, the keys are placed, appropriate diameter of the drill at each site. And this goes really fast. I mean, goodness. You can do multiple sites at one fell swing, so to speak, and it just works out very well to do. So again, appropriate diameters with appropriate keys for the drill sequence. And at this point, the implant can be placed through that master cylinder. I typically install the implant with initially the handpiece, and then always use my torque wrench to complete placement, whether I'm freehanding or, in this case, certainly guiding. So with this system, there are dimples on the mounts. So once that little key is touching that master cylinder, just part of a revolution of that mount to go to the next dimple, and we're there. And that works out quite well. Very predictable for depth. Remember, we're talking about depth of these implants. We have angulation already done, length, diameter. Now it's depth. So when we're done with implant placement, these these mounts are then unthreaded and removed. And at this point, we're able to remove the fastener pins and again, remove and disarticulate the surgical guide. And of course, our bone milling will now take place. Want to make sure there are no bony interferences. Always the tilted implants will have the more distal aspect surrounded by bone. You can't even put a milling burr over that without literally taking an 8 or 6 round burr and creating what I call a runway, like you're seeing right there with the 8 round burr. So that has to be done. You want no bony interferences, obviously, around the multi-abutments. And at this point, the MUAs are placed one by one with handles. More often than not, the distals are 30 degree. The more anterior are either axially placed or typically 17 degree, once in a while 30 degree. And they are placed in a specific 3D location, remember, because right here we have marked on the foundation guide a line, and that will line up with this set screw right here all the time. That's why you know exactly the position of your multi-abutment. There's no guesswork, all pre-planned. Remember, proactive, not reactive. So the copings now are placed one by one. Just hand tighten one of the flat surfaces to the facial. They're no longer cut, as you're seeing here. So once this is done, now of course we'll have our gasket. And the gasket, as you're going to see, will key into these little slots of the foundation guide once again. Just like the surgical guide did, now the gasket will. You see those little keys right there, and they'll fit right into the slots. Block out straws. And now, of course, the prosthesis is placed. And in this case, we have to have the opposing arch for bite registration to secure and know that we're in the proper orientation with our prosthesis before we pick it up. And of course, at this point, the straws are removed and the screws are removed. And out comes the prosthesis. And of course, hand it off for refinement. And once the gasket is removed, the bone foundation guide now comes out. And while that is being, the prosthesis is being refined, again, I'm closing. The surgeon would be closing at this point once appropriate grafting is completed. So you can see the number of defects that need to be addressed, and we can graft them and then get primary closure, of course, over the heating abutments that will be placed onto these multi-unit abutments. And now finally, the prosthesis can be positioned and secured with the small screws, these prosthetic screws. So at the end of the day, it really is about quality of life. There's no question for our patients. And it may sound a little cliches, but honestly, these folks are just so happy. Of all the work I've been involved with in my almost 39 years of doing implant-based surgical reconstruction, I've been involved with implant from day one, and after what 9 years, it's been 100% of my practice is all implant-based. And I will tell you that of all the cases, all the types of cases I've ever been involved with, they pale in comparison. Even when I was doing orthodontic surgery, those folks, for the most part, adolescents, they were very happy, of course, with their end result. But these patients, boy, it's just a whole different ball game. And those of you that are involved with full arch reconstruction, immediate reconstruction patients know full well what I'm talking about. Self-images are dramatically improved. So many of our patients come back dressing differently, different hairdos, weight loss. I mean, on and on. They just see themselves differently. And as we say it, God gave us two sets of teeth, baby teeth and permanent teeth. But now we've got a third option, and that is being able to give them back 12 teeth, typically in each arch, that are implant-based at one fell swoop. We have so many phobic patients, as we know, that are scared to death. They've been away from dentistry for years because of fear. And they'll see an ad, they'll see something that just, boom, they can relate to and say, you know what, that's me. Whether it's on television, here's something on the radio, print matter, whatever. But they're understanding that there's hope. And that's what it's all about. So that at the end of the day, they can look better, they feel better, they eat better. We are truly transforming lives. There's no doubt in my mind. And folks like Kenny, who came to us from Haiti, always smiling, by the way, just a happy-go-lucky fella. And with all he had been through, my gosh, not sure how he could be happy all the time. But after we were all of a sudden done with him, rather, my goodness, even a bigger smile, ear to ear, grin, very grateful for what we could do for him. And Jim, my goodness, wow, what can I say about this young man who gave us an amazing video testimonial that was just very motion based and gut wrenching to hear what he had to say. So grateful for the work that was done for him by us. And in turn, we as clinicians, our staff, we feel it and are happy for our patients, as we all know. It makes things so gratifying. And poor Deborah, my gosh, she unfortunately was involved with her school system. She was an instructor, a teacher for special needs kids, and unfortunately got headbutted by one of them so hard that she was so traumatized and said, "That's it, I'm done." And she did. She quit work altogether. And we had probably 3, maybe 4 consults with her before we were convinced that she'd be psychologically okay to have this work done, because that's a whole nother discussion, by the way, that not all patients really fit the bill. And I don't mean so much anatomically, but the supratentorial element is a big one. And if I can give you any advice at all, having done a lot of these kinds of cases now over the years, if you sense at all that a patient is going to be very demanding, they bring in pictures 20 years of age and now they're 72, 75, pick a number, they want to look like this, that's a problem. That's typically 2 strikes already. And then you may hear something else that is, on, and my goodness, before you know it, the demands can be ridiculous. So I would say those are patients you need to walk away from. In my early years, I couldn't do that, but you do learn, you lose hair and what you have left turns gray, and there's something about experience that it's a teacher for sure. So I guess what I'm saying is that this isn't for everybody. Again, not just anatomically, but especially psychologically. It's important that we can detect these items in patients, these traits, and discretion is the better part of valor. Just walk away. I mean, Phil, our prosthodontist, actually, he's got the patience of Job. I do not. And when he told me that one of the patients we had several years back, an RN, had been through several prototypes before she was happy with anything on the final end. One of our zygomatic patients, actually. Just amazing that he told me that she demanded that she have a PowerPoint session with him, a Zoom little conference kind of call, and she would have her own PowerPoint to show him. I thought, okay. And he actually did it, 35, 40 minutes worth. I was blown away when he told me this. And at any rate, it can become extreme. Obviously, these are folks that, unfortunately, if you don't catch them early, they will eat your shorts. And it's just not good for our own being, so to speak, because emotionally, psychologically, that drains us more than anything else. Because, as you know, we are all in the same boat. We're all wanting to help our patients to the nth degree. And that's part of our, certainly of our oath and our pledge as a profession. So, but that said, we can't save everybody, and that's important. But Deborah, we helped her immensely. And I'll tell you what, as you see here, big smile. And she is one of a number of our patients that are, again, great ambassadors for the practice, come in for our talks to the public. They're more than happy to spread the word and tell folks how these procedures have changed their lives. I mean, dramatically, brought her out of her shell, by the way. And to this day, just a big smiling lady. And Lucy, who came from the Netherlands with her daughter, fled because of a domestic violence situation, and it was just a real psychological case, so to speak, here in the States, but got things together to her credit. And when we first saw her, wow, we were overwhelmed at her story. But again, taking some time to listen and think through things, and knowing that full well that she was fine psychologically for the surgery and that she would be helped immensely. And yes, in fact, she was a big challenge because her actual facial skeleton is asymmetric, but at any rate, big challenge. But when all was said and done, once again, a very happy camper. And my goodness, can't say enough about how we transformed her, and in turn how she's helped us too, by giving us the gratification of knowing that we have changed her life. literally. So at the end of the day, if we're going to compare a conventional denture conversion, say freehand brain guided type approach, but denture conversion on the prost end versus computer guided, more or less the in sequence prosthetic protocol. If we look at the planning element alone, I think you'll agree that on the one hand, we have 2D planning, which many times is done from a Panorex or I should say even a screen capture of a cone beam CT, but the panoramic screen capture. And it's a TD workup, a 2D workup. So versus our 3D precision planning, as you've seen on the in sequence side and the virtual workup, well, I'll tell you what, it's intense. It's as detailed as anything I've ever been involved with. That's for sure over the years. There's no question. And from a treatment planning standpoint, interdisciplinary, there is no comparison. I mean, none. A true collaborative accountability is in line for the in sequence protocol, no doubt. Again, we've got the restorative based person, the surgical based person, which may be one and the same for a number of you. I know that, and that's a big advantage, certainly. But we have surgery, we have restorative, and we have the lab end, which is in Reno. And I'll tell you what, that collaboration is just amazing because we will go back and forth on different items, certainly. But the key is that we're able to, having done a number of these, as I mentioned earlier, maybe 8 to 10 arches is about the right number to do. Single arches, by the way, don't even think about diving into a double arch case. That would not be good from the beginning. Your staff will probably want to shoot you for sure, because there are too many things that can go south, not having the experience to accommodate maybe some modification that might be necessary. Like anything else, it's all about experience. And the more of anything you do, the better you get at it, of course. So what I'm saying is that this collaborative accountability is a very real one. And it's not just the surgeon, the restorative, and the lab, but of course our staff needs to be included in that discussion of true interdisciplinary treatment planning. Yes, to clinicians, but more staff's involved to a degree, certainly, and definitely as we carry out our procedure, we need them, as we all know. From an appointment standpoint, no question, hands down, advantage with this 3D approach, this computer guided approach, where we have as few as maybe 4 or 5 appointments max. It's just amazing in terms of the entire sequence of events, versus on the conversion side, a number of things can go south, not the least of which is a maintenance problem with the provisional prosthesis. That can be a real problem. And you do any volume, and boy, that can be very problematic. Chair time, that's a big one. That's a very big one. If you, in fact, are involved with conventional conversion denture cases, and you have a lab involved, whether it's a lab that shows up on wheels or one in-house, labor intensive, yes. Time consuming, yes. Versus, as you see on the right-hand side, less chair time, definitely. One of the, a single arch can be done in an hour and a half, 2 hours max. Dual arch under 4 hours, as I mentioned earlier, in general. And again, it's not a race, but time is important. Time is important from an anesthesia perspective. The less anesthesia for the patient, the better, certainly. And the less time open with that entire wound site, of course, the better for our patient as well. And then if we look at the prosthesis, the provisional itself, we typically have a denture that's converted, as I've been mentioning all along here during our talk this evening, and that is that it's acrylic, and acrylic gets its strength in bulk. And I know we do have different digital design and based dentures today, but for the most part, what has been used in the past was wrought with problems in terms of having maintenance issues, fractures, etc. Versus I have here written still the titanium reinforced PMMA. It's not any more titanium reinforced. It is a true PMMA, but it is so strong that honestly, we've not had in this last, 2.5 years or so, working with a bar-free provisional, zero maintenance issues. So that's been a real plus without a doubt. And in terms of predictability and patient specific, I mean, good night. No comparison here as well. I mean, the in sequence version is very predictable, very patient specific, to say the least, as you can see from what we've covered here with you during this session, and surprisingly affordable. I say surprisingly because it may not seem that way, but once you run numbers and appreciate what's all involved, and especially with the time savings, it's very clear that this is a very good way to go. And then how about this one? I mean, think about this. Is there anything from a medical legal perspective, anything that we do that is more well documented than what I've just shared with you? I don't know of anything personally at all. I mean, talk about a paper trail. How about a model trail, a virtual trail? I mean, on and on and on. It's all there. It's all there. I mean, every T is crossed, every I is dotted, etc. So at the end of the day, from a documentation perspective, medical legally speaking, which is so important for all of us, you have to know that we've got to be super careful. We have attorneys on every corner just wanting to come after us for any reason at all, of course. So we've got to cover our butt, so to speak, and make sure that we're well documented with everything that we do, of course. And this system really, I'd say, is as good as it gets for that discussion, certainly. So at the end of the day, we're looking at reactive, yes, versus proactive, no question. I think, and I hope that I will have been able to accomplish my main goal this evening here with you, and that is that, I say evening, my time here, Eastern Standard Time, depending on where all of you are at throughout the country. I will say this, that the goal here has been to be able to share with you this specific workflow, certainly not in a ton of detail, but hopefully enough that I've been able to explain the relative value of it from a time perspective, from a predictability perspective, a planning perspective, and most importantly, I would say, and that is this one, less stress, because at time of surgery, you're not concerned really about exactly where, for example, in the maxilla, exactly where that anterior wall of the maxillary sinus is, to make sure that you're just parallel with it. For example, posterior tilted implants, it's already been done. You did it virtually, and therefore the guide will be indicative of specific location of those implants. Again, length, diameter, angulation, on and on. So you really are not so stressed during these cases, because everything just flows, everything follows as per the plan. And quite honestly, that's the bottom line here. At the end of the day, we planned this quite well. It's taken a little time, sure, but as I mentioned, less than 10 minutes per case is all that's needed. Once you're up and running and familiar with the system, and you will have sent in advance, again, your workup, your diagnostic elements, your STL files, DICOM files, etc., all to the lab. So they will have done quite a bit of work on their end. So when you come online, you're not just all of a sudden say, okay, I need 5 implants and let's see where they're going to go. No. The setup's is already there. The optimal occlusal setup is there with the teeth and even implants placed. And once they're familiar with you and vice versa, then they already know that Picos wants 5 implants for the most part in the maxilla, and therefore they'll place them. And it's a matter of me fine tuning them at that point, once we've agreed on where the appropriate prosthetic placement of these should be, et cetera, et cetera. And in my case, I've got Phil, our prosthodontist, to have his input initially on what he had sent them, et cetera, et cetera. So when all comes together at time of surgery, for the surgical based person, the stress element is like not a big deal. It really isn't. So again, just to kind of summarize things, for the joy for me and for my wife, honestly, today, can't say enough about the grandkids. And those of you that have grandchildren can really relate probably the best. It's a very different dynamic. Certainly we love our kids, but it's a different love for the grandkids. And just I can't say enough about how much fun they've been. Little Ella is 4, and Andy is 2, and baby Nora is about 11 weeks now. So just a real joy for us. So with all that said, again, I want to give all the thanks to the folks at InSequence, Terry Capriola in particular, with all of the work that she does. She has really been the face of the company and has worked so hard to make things happen and grow the practice. I should say the entire company in such a good way that we all benefit from that. So I thank you, and certainly I'm open now to some Q&A, and I'm guessing there'll be some questions that we can answer.